Yeah, I think, I'm going to stop this. Oops, not stop, cancel, stop.
So, yeah, I mean, it doesn't.
Go ahead, Sheila.
Hey, thank you very much for joining Dr. Kevin Wasko and myself for a presentation on health networks. I'll start by introducing myself. I'm Sheila Anderson. Many of you know me as the Executive Director of Primary Healthcare Services for the Regina area. But today I'm presenting in my role as co-chair of the Provincial Health Network Project Oversight Group.
And I'm Kevin Wasko, and I'm a Physician Executive for Integrated Rural Health, and I'm presenting with Sheila on Health Networks. And I am the co-chair of the Health Network Advisory Committee sponsoring this work. And we're going to give a high-level overview of our vision for health networks and the work that's occurred, and why we're embarking on this journey, and why this is important for everyone today, and that it's everybody's work. There's been a lot of discussion about the fact that we need to build a new system based on strong primary health care model, and that can only really be achieved if all the parts of the J are focused on that fundamental structure and taking that structure into account when designing their own respective structures. So first of all, why are we doing this? Why are we creating health networks? Part of this why can be back to the patient first review. In that review, it became clear that patients perceived their care in Saskatchewan as fragmented, difficult to navigate, and that it wasn't patient-centered. The system was not designed around the needs of the patient, and that there was a lot of work to do to provide a better coordination of care and better integration of care in our system. We also know that providers are telling us that they want to see changes in the system. Recently, the Saskatchewan Medical Association conducted a survey of their members where they found that 98% of physicians believe that care is better when all professionals work to their maximum scope of practice. And what this tells us is that physicians endorse the concept of team-based care, and that we need to facilitate that, and we need to enable it so that team-based community can take root, and that we can be caring for people close to home where they live in a coordinated fashion. We also saw from that survey that 2% of physicians reported a high risk of burnout, and that we know the pressures on physicians to try to coordinate care for their patients and try to navigate the system is a stressor, and that if we can make the system fundamentally more organized in the community, that will help our providers, and by putting the support in place that we can link them to, that should make care that they provide for patients easier to achieve. So another guiding document that has led us to this work is the Saskatchewan Advisory Panel on Health System Structure, released in December 2016. And it's widely known as the report recommended the consolidation of 12 health regions into a single provincial health authority. But there were also key recommendations within it that have served as, the North Star guiding the work of the Saskatchewan Health Saskatchewan Health Authority in early days. And one of the recommendations was that one of the first areas of the new SHA should be to prioritize the enhancement of team-based primary health care across the province, and that the enhancement would deliver services more efficiently and effectively on a provincial scale, improve care to the patient and the patient experience, and would enhance care across the province, not just in our major centers. There was also a recommendation in that report that physicians would play an active role in the planning, management, and governance of the health system to achieve shared responsibility and accountability for health system performance. And we know that in the past, primary health care has been developed in Saskatchewan through incremental investment and implementation and pockets of excellence, not as much through a large-scale system change like this, but we really see that the development of health networks can help us fully implement the recommendations from these various reports so that we can see a system that is really rooted in a strong foundation built in primary health care. So following the formation of the Saskatchewan Health Authority, it was recognized that we had to implement these recommendations. And so in May of 2018, Health Network Advisory Committee was formed, and it was a tripartite group co-chaired by the SMA, the SHA, and the Ministry of Health. And one of the first goals was to agree upon a common definition of what health networks would be. And this is that definition, that health networks are collaborative health professionals, including physicians and community partners, providing fully integrated services to meet the health needs of individuals and communities. So that is, fundamentally what this is, and that it's rooted in the concept of multidisciplinary teams providing care in the community. But it is also, health networks are also geographical areas where health services are provided, delivered closest to where the patient lives and works, and that there are linkages created between the various health providers within that particular geography.
So the development of health networks is in part how we will achieve the strategic plan of the SHA. So the health networks really will touch all 4 of our health system goals. So they're really designed to connect care between teams in the community and between the community and other parts of the health system. So the structure will create a culture of accountability, and as a result will improve quality. Health networks will improve transitions in care, which will make the system safer. Health networks will also support physician leadership right at the local level and allow for better coordination and alignment of services. So Kevin said, health networks will serve as the organizational framework for all services within the SHA. So we really believe that we have a huge and a unique opportunity in front of us to kind of hardwire health networks into the development of the new SHA structure and our culture. So instead of trying to fit health networks into some type of existing structure, we have the opportunity to build it as we build our structure. So we want to connect and align with we want to connect and align health networks to many of the important pieces of work that are occurring right now across the SHA, such as organizational design, our HR structure, our cell model development, the Saskatchewan Health Management System, accreditation, etc. So along with the definition of health networks, there's also been principles and attributes developed for health networks that align with the health system for betters. And they really will give us an understanding, or you an understanding, of how health networks should look and feel. So these attributes and principles are really being used as design principles that will guide our network development. So they'll be referenced and used over and over to make decisions on how we should structure the health network and how we should deliver care. So as we build health networks, we need to ensure that they are culturally safe and responsive to the changing needs of our clients. We need to ensure that the services in health networks are delivered as close to home as possible. Really, that wellness and prevention are a foundational element in health networks. Health networks are sustainable and are connected and integrated with local physicians. So how will health networks improve healthcare throughout the province? So they'll really do this by focusing not only on the patient, but also on the provider. They will help ensure that every patient is receiving the appropriate care from the most appropriate provider in a timely manner. And by having health network services wrap around the patient, it will improve communication between providers and help the patient not have to start from scratch every time they need to tell their story. A health network would know what resources are needed for a smooth transition from acute to community or other parts of the system, and this will help shorten hospital stay. Because patients are receiving time in appropriate care in the community, they will not present to emergency rooms often, therefore reducing ED wait times and overall stress on the system. So health networks will also ensure that communities have consistent access to the care and services they require. So it's not really a cookie cutter approach in each network as to what services they're offered. The services will reflect the needs of the community and its citizens. So the creation of networks will allow the Saskatchewan Health Authority to better allocate staff and resources to meet those needs. So health networks will be designed to improve connections with our First Nations communities and the healthcare services impacting them. So now that we're one health authority, we're a very big system, and so we really believe that health networks are a way to provide services that will allow us to continue to really maintain that local community connections across the province.
In terms of how health networks will work, this visual also describes that and kind of lays out care on a continuum, with everyday health services being that biggest piece of healthcare delivery that occurs in the community, close to home. It's really the care that most people have come to know and is really should serve as the basis or bedrock of our healthcare system. Those everyday health services could mean a visit to one's physician in the clinic, in the community, or a discussion with their pharmacist in a community pharmacy. Could be a visit to a public health nurse for a well baby check. There are many ways that people get that everyday health care, and it's the hope that for the vast majority of people, they don't need to experience the system beyond that. However, when they do, we want those linkages and those connections to be strong and robust, and for the teams to exist to support those patients and feel that they're not lost in the system. When they access these intermediate services that could include home care services, there needs to be a strong linkage back to their primary provider and a team of health professionals that deliver the services to them. They may need to extend beyond the continuum to receive even more individualized or specialized care in complex services, such as specialized community services that may exist. And it's the hope that people don't need to experience tertiary level care, but when they do, when someone does need to go to our emergency departments or be admitted to a tertiary hospital, receive highly specialized care, that they do so in an episodic and rare manner, and that when that happens, they can be pulled back into the community and cared for in the community, whether it's by intermediate services or whether it's through the everyday health services. So those linkages have to be strong, and there needs to be an emphasis on the everyday health services rooted in the community.
So health networks also align to the provincial connected care strategy you may be familiar with. The strategy is about enhancing team-based care both in the community, just as we're talking about through the health network construct, but also about enhancing team-based care in the hospital. And there's many different ways that's happening across the province. The accountable care units, for instance, is one example of how we're enhancing team-based care in the hospital. In this strategy, these acute and community teams are connected through high-quality care transitions. That's the bridge that you see in the visual here. This strategy is really focused on investing in community care, where community care, as Kevin said, is where the majority of healthcare is delivered. And if you look at this slide, it's purposeful that the community care bubble in this slide is larger than the acute care bubble. So the basic fundamental component of a health network is an interdisciplinary team. And in this connected care model, both the provider type and the types of services that the team delivers are reflective of the needs of the community and its population, and are not necessarily the same from team to team or from community to community. We know that northern and urban teams may not look the same. Teams within a health network are integrated and they work together to connect community services. So multiple teams make up a network, and multiple networks make up an area. So we know that there's lots of good work going on in communities across the province. So lots of teams are providing great services, but we also know that many teams are still working in a siloed model of care. So typically working within their own provider group. So teams in the connected care model and teams that we're going to be forming in health networks really break down those service silos, and care becomes much more shared and more coordinated. So providers, people want to know how's my role going to change? So provider roles in a network model won't change, but the team that surrounds the providers will look differently, and providers working in the model will feel better supported. So the last piece of the connected care model, and a piece that's really important for health networks, is high quality care transitions. And these are transitions that connect the community teams and the hospital teams. So they're a set of evidence-based best practice transitions in care. And some examples of them are post-hospital follow-up visits or calls, medication reconciliation on discharge, advanced care planning, and discharge summaries available within 48 hours of discharge. So this set of high-quality care transition was researched by the Saskatchewan Health the Saskatchewan Health Quality Council about 3 years ago, and it was actually tested through a computer modeling program. And the model determined if we were performing all of these activities, and there's about 50 different high-quality care activities that are linked to this bridge. If we were performing all in the health system, we would improve safety and quality of the system. Patients would be better supported in the community, wouldn't have to access acute care services as often, which would improve system flow. And so part of the network design is for teams working in health networks to build the bridge of those high-quality care transitions with their acute care colleagues. So there is already some work happening in areas of the province around high-quality care transitions. There are teams that currently right now are providing in-reach services. So those are community providers or community team members going in and meeting their hospital colleagues for warm handoffs and doing discharge planning. We have teams that are utilizing technology such as SCM to be able to view the patients that they care for in the community. While their patients are in the hospital, they'll be able to view their patients in the community using technology and be able to make sure that they are pulling out their patients at the most appropriate time. And there's also teams out there that are, many teams out there that are providing post-hospital follow-up calls or visits, and those may be even with patients that they don't typically see, but that would value having someone reach out to them when they get discharged from the hospital.
Another stuff that people may be hearing about recently is a patient's medical home. And it's not a new concept, but it may be new in Saskatchewan or the lingo, and it certainly does exist in the province. It may not necessarily be called that, but a patient's medical home is basically one's physician clinic or primary health care clinic. It's a first point of contact for an individual where they need to access their everyday health needs. And the goal is that it would provide seamless care that is centered on the individual patient's needs within their community and throughout every stage of their life, and it's integrated with other health services. So certainly the concept of health networks aligns with that, and that linkage with other health services and that integration is where the health networks come into play. And they can create linkages amongst patients' medical homes or between patient medical homes and services in the community. The patient medical home is based on comprehensive team-based care with family physician leadership. And similar to health networks, the multidisciplinary team-based care serves as the foundation. Health networks, we believe, would enhance the role of a patient medical home and allow it to fulfill its full potential of offering comprehensive, coordinated, and continuing care to patients. So in any given network where there is a defined geography, there are likely to be multiple patient medical homes providing that everyday care and being that first point of contact for most people with the healthcare system. And where all the needs could be met for a patient within that patient medical home, that's wonderful, but in many instances that might not be achieved, and there would be resources that would need to be drawn into the patient medical home from the network or referred from the patient medical home to a resource within the network. For instance, a community dietitian may not live within a patient medical home, but patients that attend a patient medical home would need those services, and that's where the network would come into play and be able to provide that resource and linkage to the resource, whether it be the dietitian going for a day a week to a particular patient medical home to see patients there, or for patients to see a dietitian at some location within the community. And that's just one example of how this could work. That said, not all physician clinics have organized themselves to, fulfill what the patient medical home philosophy would be of having team-based care within the home. And in those instances, physician clinics will access the resources within a network. And when our health networks launch, there will be multiple physician clinics within a network and also multiple patient medical homes. And what we really hope is that the health networks link those together and link them to other healthcare resources. So this slide shows a visual of a health ecosystem, and at the center is the patient and the medical home where most healthcare is accessed. But we also know that very little about what makes us healthy has to do with the healthcare services that are available. There are many other factors at play, namely the various determinants of health that need to be factored in when we're trying to make our population healthy or keep them healthy. And this kind of shows how we may have at the center a patient medical home with the patient surrounded by a larger network that links the various health services that may exist. But beyond that are other factors that are factoring into one's health, education, social services, and so on. And really, the network also plays a role to create linkages with these various partners within the larger community and also linking the patient medical home. So there's a lot at play here, but the health networks would play a very important role in creating those linkages. This is just going to review a bit of what we've done to date. So as was mentioned, there is a Health Network Advisory Committee, and that is a tripartite-led group between the SMA, the Ministry of Health, and the Saskatchewan Health Authority. It's co-chaired by myself, representing the SHA, Janet Tatusis, representing the SMA, and now Mark Wyatt, Assistant Deputy Minister in the Ministry of Health, representing the ministry. And what this group is, tasked with is that very high-level strategic direction and advice as to how we would implement networks and make them a reality. We then have the network oversight group, which is tasked more with coordinating different buckets of work and trying to make the strategic direction an operational reality. And that again has tripartite leadership. And as Sheila mentioned, she is the co-chair from the SHA with Margaret Baker from the ministry and Andrea McKay, who is a staff with the SMA, co-leading that group. Under that group are 4 main work streams or buckets of work. There's model design and tool development, data and analytics, communications and engagement, which includes within it physician engagement, and then co-design and team development. And these different work streams were identified as the main pieces of work where people needed to come together to help inform the process. And on October 3rd, we had a poll planning event where we sequenced out the work that needed to occur within and between these different work streams to have a plan in place to how we would get to actually implementing, the vision. So where we are in this stage is, very early still. We have the stage of the common vision, and that's really where we still are, and where we've had to create that common vision with an agreed upon set of principles. We're now needing to create a communication toolkit to go out and tell people about this and identify the stakeholders that we need to speak to spread the message through the partner organizations and within the partner organizations about what it is that we're trying to achieve, and this discussion today is part of that. We're starting to embark on the next stage, which is the determining of the geographies for the health networks. This is a data-driven process that will be data-informed and then engaging people who have local knowledge and local context, so that these geographies can be a reflection not only of what the data is telling us about a population, but what the people living and working there also know to be true. So there will be co-design with patient and families, as well as community leaders, physicians, once that data has, informed some suggestions about what it should look like. Once we land on the geographies, we then embark on the big piece of work here, and that's the building teams. That would involve organization of SHA resources to form networks into the desired future state, and that will involve some discussions and negotiation with our union partners because it would mark a change in traditional reporting for much of our staff. Involved in that would also be the deployment of a physician leadership structure. It's envisioned that we have a physician and director co-leading each network, but that we also have physician leadership at the area level that these different network leaders report up to. We would use quality improvement methods to, continuously improve upon what we're doing here and inform us along this multi-year journey. It's not going to be something that happens overnight. It's going to take a lot of work and effort to build these teams, because we know you can't just say a team should exist and that it would. We need to intentionally build teams and work on team building strategies to have strong, robust, multidisciplinary teams based in the community. And that's going to take a lot of work and a lot of effort. And as I said, it's going to take years to really get to where we want to be. And that is going to be our big piece of work over the next few years.
So we have some experience in health networks across the SHA, and as Kevin said, we really believe this to truly be transformational for the health system as a whole. We're really excited to get this work going and have some key events coming up in the next couple of months to start advancing this work. We wanted to let you know that there's a live WebEx that's going to be planned for February 27th, and so watch for that coming out. And just wanted to thank everyone for watching and for your interest in health networks. If you have any questions that you have, please forward them to Dr. Wasko or myself, or also Adrienne Danahue, who's our lead on health network development at the SHA here, and you can see her contact information on the slide. So thanks again for joining us.
Thank you.